My name's Courtney and I'm the new Education Officer here at Respiratory Medical. In today's training video, we will be looking at an advanced respiratory assessment. I'll start by stepping you through a step-by-step systematic approach, and then we'll go on and look at some of the red flags or key findings you might find along the way. Alright, let's get started. Here at Respiratory Medical, one of the environments you might find yourself working in is in the mining industry. As of 2020, the Australian Lung Foundation estimates that occupational exposures accounts for up to 29% of lung cancers in males, up to 20% of asthma in adults, and up to 15% of chronic obstructive pulmonary disease or COPD. CAPAS is a really good acronym for a fast, generalised respiratory assessment. Your advanced assessment should add on to this with the inclusion of inspection, palpation, percussion, and auscultation. CAPAS stands for conscious state, appearance, pulse rate, effort, rate, rhythm, speech, skin, and sounds. History taking and vital signs are also integral to help inform your clinical findings and help you form your diagnoses. Conscious state, pulse rate, respiratory rate, skin, and speech are all essential when completing your respiratory assessment. For the sake of this video, I will assume this is prior knowledge and will not go into much depth. I will mention, though, any altered level of consciousness is a red flag, and sources suggest the use of GCS over AVPU. Pulse rate should be assessed for quality, rate, and pulsus paradoxus. Keep in mind that a bounding pulse rate indicates CO2 retention. Respiratory rate has been recognised as the earliest clinical sign of deterioration. Red flags when assessing skin include cyanosis and pale mottled skin, as this indicates poor circulation with limited oxygen now being shunted to vital organs. And finally, speech. Red flags include only speaking in short phrases, words, or not at all. In a general respiratory exam, appearance looks at the general impression of the patient. For example, are they distressed, calm, etc. In an advanced assessment, further include inspection and palpation. Take a head-to-toe approach to allow for a thorough, systematic assessment, and always remember to auscultate, palpate, inspect, and percuss both the anterior and posterior chest. By inspecting the face, inspect the eyes for conjunctival pallor, which may indicate anemia. Anemia is a common cause of dyspnea. Horner syndrome, characterized by ptosis and meiosis. Lung cancers that involve and damage the sympathetic trunk can present as Horner syndrome. Inspect the nose for foreign objects, nasal flaring, which indicates increased work of breathing, symmetry, and central cyanosis. Inspect the mouth for central cyanosis, an indicator of hypoxia, and angular stomatitis, which may be indicative of a respiratory infection. Move to the neck and inspect the jugular venous pressure, or JVP. To do this, you need the patient to sit at a 45-degree angle and get them to turn their head to the left. This is located between the two heads of the sternocleidomastoid. To measure for distension, measure from the sternal angle or angle of Louis to the point of the highest visible venous pulsation. In a healthy individual, the JVP should be less than or equal to 4 centimeters above the angle of Louis, where the patient is seated at a 45-degree angle. JVD occurs in pulmonary hypertension, cor pulmonale, tension pneumothorax, or large pulmonary embolisms. You should also palpate the lymph nodes for any lumps, sensitivity, or malignancies on palpation. Hands and arms. When assessing the top side of their hands, look for signs of peripheral cyanosis, which indicates hypoxia, capillary refill time, and finger clubbing. This occurs in COPD when the body has a chronic oxygen insufficiency, causing poor peripheral oxygenation. Finger clubbing may indicate bronchiectasis, lung cancer, or pulmonary fibrosis. Getting your patient to turn their hands over, observe for signs of pallor due to anemia, bruised or thin skin, which indicates long-term steroid use, and tar staining, which indicates smoking. Then, get your patient to extend their arms. Observe for any tremors. This may indicate the use of beta-2 adrenergic receptors used in asthma. Tremors are side effects reported in 2 to 4% of patients with asthma. Getting your patients to flex their wrists back, observe for asterisks. This looks like a flapping motion, which indicates CO2 retention that occurs in respiratory failure. Assess the temperature of the arms to indicate circulation. Moving to the chest, start by palpating the trachea. You're checking to see if the trachea is central within the suprasternal notch. A deviated trachea can indicate a tension pneumothorax and is therefore a red flag. Observe for scars, increased chest diameter, elevated sternal notch, and spider naevi. Next, observe for accessory muscle use. Here is where I add palpation. After gaining consent, place both your hands on the patient's chest wall to feel for the chest expansion on breathing. Chest wall expansion should be equal and symmetrical. Asymmetry is a clinical red flag as it is suggestive of pneumonia, pleural effusions, tension pneumothorax, and rib fractures. Next, locate the cardiac apex. This is located in the midclavicular line of the fifth intercostal space. It's normally below the sternal angle. In lung hyperinflation, the apex beat is impalpable and heart sounds are inaudible. This is due to the upper left lobe of the lung being in between the heart and chest wall. You can also look for right ventricular heave, which occurs in pulmonary hypertension where the lower sternum is lifted. Next, you want to palpate for subcutaneous emphysema and crepitus, signs of trauma, especially pneumothoraxes. Observe for chest deformities. Ensure to inspect and palpate your posterior chest. Working down to the lower extremities, observe for any sacral edema, peripheral cyanosis, or deep vein thrombosis, DVTs. It is important to examine the legs and observe for any signs of calf tenderness or localized warmth. Signs of DVTs are clinical red flags as it can easily develop into pulmonary emboli. You should also look for peripheral edema. When assessing the effort of breathing, you're looking for signs of increased work of breathing and the depth of breathing. You should note whether their work of breathing is mild, moderate, severe, or inspiratory, expiratory, or both. Signs of increased effort include tracheal tug, intercostal recession, paradoxical breathing, and tripod positioning. Other signs you should observe for include Hoover sign, Dahl sign, and Harrison-Skalkis. Next, observe the rhythm of breathing. Look for signs of prolonged inspiratory or expiratory phrases. Respiration is controlled by pH and PaCO2 levels. The chemoreceptors adjust tidal volume and rate based on these levels. When assessing the sounds, this encompasses chest auscultation. As seen in the diagram of pulmonary anatomy, the lungs have several lobes. It is important that during auscultation, all lobes and lung fields are examined and auscultated. Start at the lung apices and work your way down, comparing right to left, as seen in the diagram. Keeping in mind that breath sounds are created by air turbulence, the aim of auscultation is to assess airflow through the trachea and bronchial tree. A wheeze is low-pitched and dependent on where it is heard, indicates upper airway obstruction, widespread airflow limitation, or bronchospasm. Stridor is high-pitched and indicates upper airway obstruction. Crackles are short, explosive sounds, representing the sudden opening of collapsed small airways. And finally, pleural rub is a grating sound, indicating pleural inflammation. All adventitious sounds warrant the need for further investigation. Absent breath sounds indicate limited or no air movement throughout the airways. This indicates a severe respiratory condition. Vocal resonance and tactile focal phrenitis both conclude the same assessment findings, so it is recommended that you do one or the other, not both. Vocal resonance is a good indicator to how well the lungs can transmit sound. It is assessed by getting your patient to repeat 99 while you auscultate the posterior lung fields. Over a healthy lung, the spoken sound is deadened and muffled. Vocal resonance is either absent or greatly diminished over pleural effusion and pneumothorax, but increased in consolidation, lobal collapse, and tumours. Tactile focal phrenitis is assessed by palpating the vibrations through the chest while the patient speaks. Again, decreased vibration indicates fluid or air outside the lung, pneumothorax or pleural effusions, and increased vibration over an area suggests increased tissue density, consolidation or tumour. Percussion differentiates areas filled with air, fluid, or a solid. When an area is air-filled, resonance is heard. Hyperresonance therefore indicates lung inflation. When an area is fluid-filled, dull sounds are heard, and if solid, a flat sound is heard. It is important to note that cardiac dullness is expected to the left of the sternum and is about the size of a fist. Further, dullness is expected over the area of the liver. Another thing to consider is the analysis of blood chemistry and blood gases. In today's growing pre-hospital environment, the accessibility to blood gas interpretation is increasing. When available, blood gas interpretation will be able to show if your patient is acidotic or alkalotic and whether this is due to respiratory causes. To finish today's training video with a couple tips and tricks. Firstly, rest and reassurance will go a long way in your respiratory patients. Decreasing their level of anxiety will decrease their respiratory rate and hopefully decrease their work of breathing. Secondly, keep it systematic. Try and keep it to the KPES format with the inclusion of inspection, palpation, percussion, and auscultation. Well, that concludes our video for today. Thank you for watching. Best of luck.